Ladies and gentlemen, Loïc Vaes.
Good afternoon. Thank you for being here. Thank you to Couchbase for giving us this opportunity to present our project. My name is Loïc. I work at AEDES. AEDES is a consulting company. We are specialized in public health and active in countries in the developing world, mainly in French-speaking Africa. So AEDES exists for 30 years, and we are 20 people in Belgium and about 50 to 70 people working on the field in Africa. Inside AEDES, there is a small team of people, two of us, working on a software, Ceres, and Ceres is a hospital information system for small and medium hospitals in those very challenging environments in Sub-Saharan Africa, particularly the Democratic Republic of Congo. So let us look at the current situation in those hospitals. Everything works on paper right now. So you have those registers, and on a register there is a line for each patient. You will write the name, the last name, the birth date, information like that, and it's written chronologically in the registers. So let's take an example of a patient who comes from somewhere to go to the hospital. He gets to the admission, and there they will write his name, his first name, address, everything, and then send him to the doctor. And the doctor will write the same information once again, ask him about his name, last name, so each time you write everything, and then the problem he has. And then he will send him to the laboratory. And laboratory is again the same deal. It's another register because there are about 25 of them spread in the hospital, and he will write all that information, the type of exams, and the results, and then send the patient back to the doctor. And it goes on like that also for the medication, and then if it's a hospitalization, the patient will go from one department to another department. So with that, we have things like for the laboratory, we have 1,500 exams every month. So you have 1,500 lines that are written over the month. And the problem with that is that at the end of the month, you have to fill a report. It's a requirement from the National Health Ministry. And in that report, each little cell is the result of a calculation, a query that you do from your registers. So if we look at the laboratory register, it means that in that case, in the small or medium hospital, they will have about 20 different exams. So they will take a counting sheet, write the name of the exams, and then go through the registers and count for every line, every one of those 1,500 lines, put a little bar next to the name of the exam, and then after that they will count everything and write it in the form. There is between hundreds and thousands of those little cells because the paper is 20-page long, the report. So now we have another problem. It's the archiving is problematic. So here we have the archiving system of a hospital I visited recently. And this is the archives from 2012 to 2015. This is not a very bad case. It's a regular system. And they just have so much information that after a while they have to put it somewhere. And then you have heat, humidity, you have rodents, insects. So it's very hard to get back to that data. And one of the motto of Couchbase is liberate your data. And I think this is a good example of literally the data is behind bars. So that information is very important for different reasons, including, of course, care of the patient. And that means that you want to have access to his patient history. And when he comes back the next month, you don't want to have to go back in the registers. And then also for the hospital management. It's important for them to know the use of the different departments, and then they use that also for human resource management, things like that. Also, at the level of the National Ministry of Health, they need information because they are, as role, they have to provide quality care to the whole population at an affordable price. So for that, they must take decisions that are based on data. But their data comes from those papers that have been filled, the paper reports. And we know that there were several mistakes when you have to count lines and then write it on a sheet of paper and write it back in a form and then write that form in a software. So many countries there have this very nice software, which is DHIS2. But the problem is that we have that phenomenon of garbage in, garbage out. However good is your software, if the data that you input is not good, then the data that you see at the output is not very useful either. And of course, a fourth very useful thing for the information is data for epidemics. And I'm thinking here about cholera or Ebola. So this is a good case where you would want to have an electronic system to handle your information. It's a hospital information management. You can do that, and you have it in Europe, in the United States. You have it in many places in Africa, in large hospitals or private hospitals. But in our case, we are talking about small and medium-sized hospitals in very challenging environments. Places where before people thought it was not very possible to put it. So let's look why this is a challenging environment. One of the first reasons, of course, is the limited financial resources. They have very little money, and you have to put it and use it very efficiently. And then there is a problem of unstable power supply. This means sometimes you have no power at all, or you have power, but it's not very stable. More generally, it's the whole system that is very complicated to place because you have humidity, heat, dust. And in my experience, when you go to one of those hospitals, everything that you have that can break is going to break. You have also the problem of poor internet connectivity. Again, sometimes you have internet, sometimes you don't, sometimes you have a good internet, but it's too expensive. So you cannot rely on it. Cloud solutions is not an option. Remote monitoring is difficult too. You have also the fact that end users are not familiar with the things like Windows or laptops, desktops, so you need to find easier solutions. And then the low availability of qualified technicians. And it doesn't mean that they don't have good technicians. It mostly means that there are not many of them and that they are very expensive. So for small hospitals, it's difficult to hire one. Those technicians also will tend to stay in the cities and prefer not to go live out in the country. And then we have also another constraint, which is the fact that it's large quantities of data and very diverse. And this is because it changes from one country to another country, and it changes from one type of hospital to another type of hospital. It also changes from year to year. So you cannot have one model fits them all. So we have all those constraints, and we are looking for a solution to put a system that is useful in those type of hospitals where it's complicated and where before we deemed it not possible. So the solution that we offer is Android devices. It's those nice Samsung tablets in a protective case, and they replace the registers. So they're also in a local network. When we look at the constraints that we can address with that, it's, the first one is the limited financial resources, since tablets are less expensive than laptops or desktops. Also the problem of unstable power. This is because the tablets have batteries included. And also poor internet connectivity because the system works on a local network. And then very importantly, the end user being unfamiliar with ICT is no more a problem, because while a few percentage of the population has ever used Windows, most of them have access to smartphone or know someone who does, and anyway, Android is very easy to use. So that's a big advantage too. This is what our application looks like. You have here, you can see the screen of the patient history. So on top of it is the administrative data, and you can get to more details. You have the name, the last name, and so on. So as a reminder, in the registers, you have to write it maybe 10 times, 25 times for a single visit. Here, you write it once for the history of the patient. Then beneath that, on the left, you have the history of the patient. Those are different visits where the patient came to the hospital. And for the first one, you might find it in an easy way, but all the other ones would be lost in that room I showed earlier with the bars. And then when you select a visit, on the side, on the right side, you have all the events that have happened. So here is an admission, and then the person went to the doctor, did some exams, and so on. This is what it looks like for the users. It's forms that they have to fill in. And for example, it's a list of the different pathologies that they can fill, so it's easier to make queries afterwards. So now, where does Couchbase comes in this story? This is a diagram of the architecture of the system. On the right, you have the server. Server runs on Ubuntu, and it has a Couchbase server with 4 buckets. One bucket is for the users, another for the data, which is a very important one, and then metadata that helps us to define which data will be used. You have also a 4th bucket, which is for stats. And then all those buckets, also part of them are present on the left on the client. Client has an application in Android, and then works with Couchbase Lite. So we have a local database on each tablet. And it has a copy of the buckets that are on the server. Except the 4th bucket, the stats, and the stats that are populated from the data are done by running with a cron tab job, Node.js that runs the Nickel queries every night at midnight. And then we can access this data with an API. So why is Couchbase so useful for us? Well, first, it's free and open source. We use the community edition. And then a selling point is enabling offline mode. And I see that in the previous presentation, that was also something that was put in the front. And that's definitely something that is critical for us. We met some people, especially at the ministry level, who told us, OK, you want to install a hospital information system. We tried that in the past, and it didn't work. It didn't work because the network went down, the server went down, everybody went back to paper. And with those tablets, since they have a local database, you can keep working. And then when the network reconnects, all the data synchronizes again. We have a team of 2 programmers. This is something just impossible to do if we didn't have it given by the database. Also very important for us, and I see that we're not the only one thinking about that, is that it's a very reliable intranet setup. We just set the server in the local network, and our experience is that it just works. We have no problem with that. We have problems with everything else, but not with the Couchbase software, which is good. Also important is the fact that it works on light hardware and that it handles horizontal scaling. This is important for us since cost is critical, and it allows us to do things like offering hospitals to test the system for maybe 1 or 2 departments. And if they want to put the system on the whole hospital, they don't have to replace the server. They can just add another small server. Also, the database is adapted to our data model, and this is because the NoSQL documents, they just fit. One patient is one document, one lab exam is another document. So this is very useful for us also because the data changing every year. Using a schemaless system is an advantage since you can access past data that way. So to go back to the point, the constraints where Couchbase is most useful, it is for the limited financial resources, as I said, and then the poor internet connectivity, since we can make it work in a reliable way in the intranet, and then low availability of qualified technicians, because we use Nickel, and it's quite easy to move from SQL to Nickel, and then the servers are very easy to launch. Also, the large and diverse quantity of data, I just explained this. OK, so this is more than just software for us, because you cannot bring the tablets in a hospital and hope that it will work. So with the University of Brussels, we have developed this chest. This is used to charge the tablets and protect them. It's a modular system. On top, you have a part where we have the server and the network, the router. And then the middle part is where you store the tablets, 10 tablets for one little part like that. And then at the bottom are the batteries. And batteries are alimented by the solar panels or the electricity from the grid whenever it's available. So this kind of system, we can just prepare it and then bring it with a pickup to a hospital and then plug everything together and launch the system. Another element that we have set up with the Polytechnic School of Brussels is a system of monitoring by SMS. Again, we don't have internet in all those hospitals, so we have those small SMS that are sent every day from the hospitals to a central server, and then it is sent back to the local technicians. Also, when there is a problem with the batteries, for example, we get an SMS for it. And this monitors the level of the batteries, the state of the server, also whether the solar panels are working or not. And it allows us to avoid sending technicians all the time in the field. They can go there directly when there is a problem, but they don't need to go there all the time. So, of course, there is the software part, the hardware part, but more than that, it's a question of people. And for that, we work with local technicians, and this is something that is very important for us, the transfer of knowledge. Here you have a picture. I think it's an imported one, because on the right side is Martin. Martin is the programmer for the application. And you have our 4 local partners. And it's an important picture because it's a workshop at the first unofficial Couchbase Connect Congo. So we had 5 attendants. We did a training for a few days about Couchbase and then our application. And those guys now are doing the configuration for the hospitals we are working in. They also take care of training, installation, and maintenance. This is important too because when you look at a country like Congo, it's almost as big as the western part of Europe. And they have 500 hospitals, public hospitals, and 9,000 health centers. So we were counting with those guys, and if we could install the system in each hospital in one day, it would take us 25 years. So definitely we would have to form other people, and they can form other technicians, and that's the way we want to evolve with people on the field. Now what about the next steps? So when you put those tablets in the hospitals, people are very enthusiastic, and quickly they are requesting new features. Something we have each time is the requests for a billing system. So their thinking is that since you're recording all the events that are happening, or the medication that is given, you can also easily produce a billing system. And we are working with that. We are working on that with an intern who is currently in Congo testing that part of the software. People also request a system to manage the pharmacy, the medication stock, and then more fancy elements like an help for the medical diagnostic. Some of those health centers do not have doctors, only the nurse, so it could be helpful there. And then a system of appointment scheduling too. For example, a mother who has to come to a first prenatal visit, and she should come 2 months later, and they want to make sure that she has come, so if she did not present herself, they send an SMS. But we also want to improve some technical aspects. And amongst those is removing the single points of failure. So this concerns, amongst others, the server and the network. And for the server, we're very enthusiastic to work with the peer-to-peer system. And I was talking about that with Fujio earlier. And we know that Couchbase is working on that. That's something we would like to try. Also, making deployment and maintenance easier. This is to make the task easier for the local technicians. And for that, we're looking at Docker as a system. And then dimensioning the system more precisely. Again, limiting the cost is really important for us. So if we can have tablets that are as inexpensive as possible and solar panels that are as small as possible, this would be very helpful to limit the cost. And then, of course, implementing new mechanisms. This is about the sync function, for example. So currently the system is tested in Kinshasa, the capital of the Democratic Republic of Congo. And I'm going there next week to install it in 1 hospital and 3 health centers in Kinshasa again. And then in December, I'm going to Burundi to install it in 3 health centers. But we are looking to install it in other systems too, or in other countries too, and those are mostly countries in French-speaking Africa, because that is where AEDES is very active since many years. So that's our system, and I'm very thankful that you could be here this afternoon. I'll gladly take questions maybe after, when I'll be around, and you can come to ask them, or ask them to Mehdi, who is my colleague here. And thank you very much. Thank you.